On today's program, can hospice be saved?
Hospice is still doing fabulous work, but it's in existential danger.
All across the country today, hospice nurses are visiting their patients, making connections with families and communities.
You been up moving around a lot?
Oh, yeah. I did a whole lot of moving around over the weekend.
Well, you know, they say they can't keep a good woman down, so.
What started as a charitable movement to care for the dying has morphed into a $22 billion business. And some believe it has lost sight of its mission.
I don't think it's lost exactly, but I think if we don't act swiftly and really push back against the commodification of hospice care, it will be lost.
And I think you can go through the motions, make all the visits and document the way you're supposed to, and still people don't feel cared for.
In this age of investor-owned hospices, we talk mission, margin, and the soul of caring today on the Hear Me Now podcast. Stay with us. I'm Seán Collins. Thanks for listening. Hospice is in turmoil. At the end of last year, the New Yorker magazine, in tandem with ProPublica, published exposés documenting fraud and neglect in a number of investor-owned for-profit hospices. The hospice industry pushed back, saying what Ava Kaufman described was limited to a few bad players, bad apples, if you will. But my guests today, Dr. Ira Byock and Dr. Glen Komatsu, think there's more to it than that hospice in the U.S. is at risk of losing sight of its mission and losing its soul. I'm happy to have Drs. Byock and Komatsu back on the podcast. Gentlemen, it's good to see you both. Welcome back.
Thanks, Sean.
Hi, Sean. Really nice to see you, too.
I want to start with the notion of mission. And I think there's probably no better voice to hear from right at the beginning than that of Dame Cicely Saunders, the nurse turned social worker turned physician who is credited with being the foundress of the modern hospice movement. Dame Cicely died in 2005 at St. Christopher's Hospice in London, which she founded. But she wrote extensively about hospice and the reasons for this type of care. And she taught students to appreciate the needs of families. Here she is describing hospice in the 1970s.
When we look at the whole spectrum of the needs that a person as part of his family or her family may have at the end of life, we can be very daunted and feel, I can't possibly cope with that. I'm a simple doctor. I know how to deal with physical things, and that's what I should be doing. But we're not here on our own. We should be very much part of a team. The nurses, the physiotherapists, everybody who is involved with this patient is part of the team. And to be able to share is enormously important in this work. If you think it's only I who understand this patient and can deal with it, that's a dangerous position to be in. And it may not only be the patient, it may be the family. It may be the child of the family that needs to ask the question of the doctor. And it's very important that when we're thinking of the whole family, we don't leave the children out, because it may make a big difference to the whole of the rest of their lives, how they handle the death of a parent or a grandparent or a sibling. I think the physician has to look at his own sense of meaning of life, and that has to be an involvement at the real depth of what it means to be human. What we're looking at, I think, is the whole area of spirituality, which is much wider than a purely religious practice. It is, I think, the search for meaning, the look at one's own most important values, the feeling of looking beyond yourself and of somehow belonging to something more than you are, be it maybe only your own family network. But there is something about knowing who you are and looking back on your life and coming to terms with it and being able to lay it down with some degree of quietness, which I think is much deeper than just psychological, and it's something to which I would give the title spiritual. And I think that is part of man. And to leave that on one side and only look at the body and the physical side is to shortchange people. People are more important than just that.
The founder of the modern hospice movement, speaking in the 1970s. Ira Byock, would Cicely Saunders recognize hospice in America in 2023?
Yeah, having had the privilege of knowing Dame Cicely, she'd be disgusted. I think she'd be aghast.
Glen, you're nodding.
Yep, I agree.
Ira, your own writing, starting with Dying Well in 1997, has been foundational for the growth of hospice in America. That book absolutely changed my life and how I think about human community. And there are 3 words from it that are burned into my consciousness: clean, dry bed. They are a pledge of accompaniment, a proof text that you are caring for someone, that people deserve to be cared for and not abandoned in their final days.
You know, one of the earliest historians chronicling the early development of hospice care described hospice as an intimate transaction of people living in community. And I think that, offering people at its basis a clean, dry bed, making that an absolute bottom line, is reflective of that approach. That this is about living in community with one another around issues of illness, caregiving, dying, and grieving, and we in medicine. I'll speak just as we physicians. I don't mean to be overly chauvinistic, but just keeping it within my own discipline. We layer on to that, contribute to that community response, technical expertise in diagnostics and therapeutics, and bringing the pharmacology and technology to bear in service of giving people, the best care we possibly can in the context of their own lives, their narratives, their families' lives, and as a human community.
Yeah.
Now, by the way, we come to a time when hospice care, unfortunately, has become transactional and commodified. And it's nobody's ill intention, but it's inconsistent with what we thought we were building.
Ava Kaufman's reporting last year on ProPublica and in the New Yorker really took hospice to task across the board, but it focused on for-profit, investor-owned hospices, saying that they had become for-profit hustles rather than mission-driven healthcare. There was pushback from the leadership of the many professional organizations that represent caregivers in hospice. And they said basically a few bad actors doesn't damn the whole system, which is certainly true. But what is also certainly true is that the landscape of hospice has changed by the arrival of investor-owned companies who are focused on returning a profit to shareholders. It makes me wonder whether there's something just antithetical about for-profit hospice, that when margin trumps mission, the mission is going to get lost.
Yes, but I don't think it's the corporate structure or the tax status alone. I think it is allowing profit to trump mission. What we've seen is most egregious in the for-profit corporations, particularly the private equity owned or investor owned, shareholder owned corporations that really have become, excessive in their need for ever greater margins. For one thing, I don't think there's anything innately wrong about being a for-profit healthcare company. Hell's bells, I'm an American. That, capitalism is patriotic. But at some point, uh, whether you're a nonprofit, in which margins still matter a lot in nonprofit corporations, it turns out, or for profit, at some point, enough is enough. And at some point, there's tension between your margin and delivering consistent, reliable, high quality care. And we have now exceeded that, particularly in some of the most avaricious for profit companies. I mean, the government's own report, Medicare's own report, uh, documents that for profits on average are making 19% per annum margin compared to 6% for nonprofits. You know, uh, at some point, that erodes quality, and it does so by diminishing the number of doctors for your patient load in your program, their scope of responsibilities that you're paying them for, increasing caseloads that nurses are carrying to the point where it becomes really untenable, and you're delivering inconsistent, unreliable care, and you're burning out nurses who are dealing with constant moral distress, constant fatigue of doing their charting at 11 p.m., all of that. And you're understaffing nurses' aides, and you're not providing respite care, and you're not providing general inpatient hospice ICU levels of care, and you're not providing bereavement support to families, or all of that. And that has now happened. All of that, it's not, it is more than a few bad apples. There are certainly excellent programs. And by the way, Dr. Komatsu, runs one. But this is no longer rare. And can I go say one more thing before I just get off of this rant? And that is what really bothers me, maybe the most here, is that the associations we helped form, we paid dues to, we support in all kinds of volunteer educational efforts and all kinds of work that we do for talking about the Academy of Hospice and Palliative Medicine, the National Hospice and Palliative Care Organization, among others, are refusing to accept any measure of responsibility for this happening. And we all saw it happen with eyes open. I can tell you I've had more conversations with leadership over the last 3.5 decades about this very issue than I can remember. And they haven't responded. And that's not an omission, like we've had other priorities. That was by intention. They decided, nope, we're going to kind of let the market sort itself out, or we'll let Medicare figure this out. And they haven't. And even today, they refuse to accept responsibility for seeing this happening and not responding. In fact, even today, all of the issues that Ava Kaufman wrote about, I piled on with an essay in Stat about poor quality care being different than fraud and abuse, but overlapping at times. That this has happened in real time. The associations are allowing it to happen today. Nothing substantial has changed.
We have a link to that essay in Stat that you wrote 7 months ago. We also have copies of the response from the organizations in which they make the bad apple argument, and as you say, don't really take any responsibility for what's gone on in their industry. And I use industry purposefully there. I hate to talk about medicine as an industry, but this seems like an example where it's exactly the right word to use to describe what's going on in hospice. Glen, you're spending every day working with patients, and I'm curious what your sort of immediate take is on this tension that Ira is describing.
Yeah, thanks, Sean. The great thing about being on with Ira is that he is much more erudite and articulate than I am. And so I totally agree with everything he said. I don't think there's inherently anything bad about being a for profit, just like we in the nonprofit world are not necessarily great providers. The tension between mission and margin is ever present. And I'll tell you, we look at our financials every senior management meeting. And, we're graded, green, yellow, or red. And the leadership does not want to see red, when we're losing money. And so we're just trying to lose less money and break even, really. And we're not really succeeding, our organization anyway, just speaking for us, we're not really succeeding in that. So we have a really active foundation that raises, a ton of money to support our programs. Because to do cutting edge work that's not well reimbursed requires philanthropy. And so that's how we're able to maintain our standards and our stature in the world. But it's difficult. It's really hard. And we pay attention to the bottom line just like everybody else.
That's all true. And by the way, I, in full disclosure, I have worked with Glen. I was part of the Providence corporation, nonprofit corporation, but I'm also a donor to the Trinity Care Foundation, and proudly so, because it is again part of a community taking care of its own. That through the vehicle of Trinity Care and Providence Hospice and Palliative Care. So that's not a illegitimate way of thinking about what a healthy community response is to the fact of human illness and caregiving and dying. But the irony here is that because of the work I've done in academia and through the Institute for Human Caring, I know that the work that hospice is doing is actually saving the larger health system substantial amounts of money. And that while Glenn says, well, we're under pressure by senior management to make a margin here and all that. Well, yes, in a very unsophisticated kind of accounting of 20th century accounting of a profit and loss sheet, yeah, they're losing money. Right. But if you look at the global total costs of healthcare for human beings, they, without hospice and palliative care, the cost per patient would be far higher. Mm. And this is not just philosophy or general principles. We have data that shows that the early involvement of palliative care raises quality and substantially diminishes costs.
Right.
So it's really the accounting system that's part of the problem here, really more than the excessive costs of having enough physicians and nurses to care well for seriously ill and dying patients.
Eric Cassel's book, The Nature of Suffering and the Goals of Medicine, has a section which I think is called A Simplified Description of the Person, which of course is not a simplified description of a person. It's one of the most poetic, complicated descriptions of what makes us who we are. And one of the points that the balance sheet view of medicine misses is that there's so much to us that never makes it onto a balance sheet. And that was the great hope of hospice, I thought, was that here were caregivers who cared about the complexity of the patient in all of the ways that we're complex. Our relationships, our fears, our hopes, our secret lives. All of those things are present at the end of our life and need to be cared for in some way. And here was a group of people willing to sit there at the bedside and nurture the person. And then you read what the New Yorker published and what ProPublica published, and what you're describing as being part of the conversation that's been going on for years. And you realize maybe that's a pipe dream. Maybe that care doesn't happen anymore.
It does happen. It still does happen. Hospice is still doing fabulous work, but it's in danger of it's in existential danger, and that's not just philosophy. Um, uh, there are a lot of bad apples in the barrel these days, not just a few, but there are, I like to think many more good apples still today, though the barrel is infected and it's going quick. Things are going to spread quickly. The influence of the business environment and the accounting, what hospice is being held accountable for financially is really rampant. We have never sort of set clear standards for what quality looks like. There are things we could do to maintain, to describe that intimate transaction or intimate relationship, really, of people living in community. Um, and and there's been this remarkably odd resistance to doing so, as if we put out there firm standards of responding, time and responding to emergencies, or how many patients it's safe for nurses to carry, or how many doctors are necessary per 50 patients on your average daily census, or whatever, that somehow we'd be offending some of our programmatic colleagues. I don't think it's lost exactly, but I think if we don't act swiftly and really push back against the commodification of hospice care, it will be lost. And let me say one other thing, that, we know that the way hospice has been paid for under Medicare is changing. It's already changing, and it looks very much like hospice will be, quote unquote, carved into general Medicare. It has been carved out of responsibilities of the general Medicare providers. But if it's carved in under Medicare Part C or Medicare Advantage, without there being clear parameters for what really hospice requires in terms of services, functional definitions, then it's just going to go away. These Medicare Advantage companies, United Healthcare and Kaiser and others, are just going to assert that they do hospice care, and there will be no effective way of saying no, you don't.
Yeah, Ira has done really groundbreaking work in quality improvement in hospice and palliative care through the Institute for Human Caring. All the measurables that he just alluded to. But Seán, what you just talked about in the nature of suffering is more qualitative. And I think that's really hard to measure. And I think you can go through the motions, make all the visits, and document the way you're supposed to, and still people don't feel cared for because people didn't bring the qualitative aspects to the work. And by qualitative, I mean uh, qualities like love and joy. After doing this work for decades now, I really have come to appreciate the culture that we've tried to create at our hospice, and specifically in my small pediatric team. It's like, what do we bring that differentiates us from, the care that these children and families get at four of the best children's hospitals in the world in Los Angeles and Orange County. And it's that qualitative difference. They get the best medical care, in these children's hospitals, but they don't get love. They don't, the caregivers don't bring joy to the work and help the families and the children recognize joy when it comes up. Even, those small slices of joy, even as kids deal with terminal illness. And that is what differentiates, I think, really, really great hospice care from average hospice care.
Dr. Komatsu, can you elaborate a little bit more on how those qualitative values get communicated to a staff? How do you inculcate new folks when they're onboarded that this is what we're about?
Yeah, yeah. That that really is a great question, Sean, and I'm still trying to figure that out. But what I try to do as a leader is model that and talk about the joy that this work brings to me. I really take every opportunity to support my team. When I get a phone call and a nurse has a question for me, it's like not only do I answer the question, but I take time to explain to him or her why we're doing this way. I take time to thank them and show appreciation for their concern and their time that they spent with the visit. And I try to show that to parents when I'm visiting them and thanking them for allowing me into their home, allowing us to take care of their precious child. It's the small things I think that add up to a different culture. And I see that in the nurses. They taught me really about the value of love. They come to me and say, and this is when I was a neonatologist too, I love this child. And, I didn't grow up in a culture that was, where we said those things. And it took me a long time to get past my own sort of biases that, nobody talks about love in medical school. Nobody talks about love in medical training, right? That's like antithetical almost. And love is really what we bring to the table. I know I was giving a talk to one of the big healthcare organizations about Alzheimer's disease, which I'm far from an expert in. But when I was preparing my remarks, we have very few medications that currently do much of anything in advanced Alzheimer's disease. And I thought about what does my hospice bring to the table to help these patients and families. And what we bring is love and kindness and patience and support. Because at the end of the day, that's what those people need and what the families need to keep going because it's so hard. It's so hard to deal with, uh, a person with dementia in the last part of their life.
Ira, when you and I met um, more than 30 years ago, um, you were still working pretty routinely in a hospice in Missoula, seeing patients every day. And um, I walked away from that thinking I've met a physician who has clinical expertise, but has something else going on that makes him a human being, a mensch at the bedside. And I thought that was what all of hospice was going to be about. That modeling that Glen just described, that others would pick up from folks like you two. And I kind of wonder where your colleagues have been through all this. Why haven't they pushed back as much as they could. Why haven't they spoken up?
The forces of what has become the industry are very strong. The expectations for productivity and various other types of performance are really very difficult for any individual physician to counter. Um, I was smiling broadly because as Glen was talking, because I so ardently believe and affirm what he said. It is that qualitative sense of presence, the ability to listen and acknowledge the uniqueness of this person is very difficult to describe in objective terms or to measure. But I'm going down swinging. I keep trying to describe it in ways that are measurable or reflected in things that we can systematize. One of the things that I've tried to do is talk about the phenomenon, the human potential for well being coincident with dying. And joy, which Glenn mentioned, thank you for that, is one of the telltale signs of or components of well-being. If you can laugh, or somebody can laugh or giggle or feel joy for even moments at a time, their capacity for well-being is intact, right? And speaking of Alzheimer's, just as an aside, when I'm working with somebody with advanced Alzheimer's disease, to the extent possible, I try to go directly for the joy. what can we do to elicit a smile from this person? What, is it putting a baby in their lap? Because if they're still cognizant at all, that's a trigger often. Is it massaging their feet? Is it a piece of birthday cake? Is it whatever the hell it is? Music is a good one. That movie Alive Inside, which you can still see on Netflix, is if people listening don't think that people with advanced Alzheimer's disease have capacity for joy, just spend a few minutes with that movie Alive Inside. It'll change your expectations. But defining well-being as part of the extent of human potential, not just comfort and alleviation of suffering, that helps us in one of the things I've tried to do, and Glenn, I think you know this, is when I'm managing an interdisciplinary team meeting, we pause toward the end and say, what are the opportunities to respond to suffering here? What are the opportunities we have for well-being? What can we help this person not only feel less pain, but also have a sense of completion, maybe celebration, recognition for their accomplishments, not just their woes, all of that. Those are things that can be systematized to kind of hold open the capacity for whole person caring, right? To acknowledge caring in the context of the person's life, not just in the context of their damn problem list. I've tried to bring measurement to that as well, but so I'm going down swinging on this. It hasn't worked yet, I have to say. The P&L sheets and the old style ways of accounting for quality and performance are all about the medical model and are kind of depersonalized. Eric Cassell and his concept of personhood gave us dimensions of the person that may still have the capacity for well-being, despite the fact that one's physiology is eroding.
Right. Well, I guess it's my job as a quasi-journalist here is to ask, what could fix this? What could turn the corner? What could affect change that would be meaningful?
I can be the first to say I have no idea. I really don't. I know that I can only take care of my side of this relationship. I know things that I can do. Speaking the truth, spending so many damn hours writing, essays and letters and trying to just put it out, doing podcasts, just trying to put it out there, partly to hold a mirror up to those in power in our national associations, but all of our colleagues, as well as Congress and Medicare and the regulators, and all of that. I have to say, and this is going to expand the conversation a little bit, that the same problems we're having in hospice care are the same problems impacting so much of American life and society. And it is the commodification of everything and the private equity ownership of damn near everything. Right now, as we have this conversation, the writers' strike in Hollywood is approaching 110 days, I think, and that's all about private equity owning the vehicles of entertainment and creativity be damned. Now Netflix is asking their writers to create content for second screens, right? You know what I mean by that? I mean, it's like what I
No.
do with Major League Baseball. Don't hate me for saying that, Sean. But that may be up on a second screen that I'm watching. That now that's what they want. They don't give a damn about quality. They don't want to pay writers for their creative works. They just want stuff,
Yeah.
and it's all about margin.
Glenn, any hope here?
Yeah, one of the things I admire most about Ira is that he's used his platform in such an impressive way. Because of who he is and his contributions to the field, one of the founding fathers of the field and one of the most influential people, he's used his platform to write his editorial pieces that get put in the New York Times and the LA Times, and so I think that is really great, and I think that's I really am impressed by that. I don't have the same platform, and so I have my own little laboratory of work in my local area, and I'm trying out things to see what works and see if I can create a culture that really promotes love and joy in the work, that helps sustain us, by the way, and mitigate against burnout. Those are the things. If I can, sort of do smaller things on a smaller scale, and then I can talk about it, in bigger audiences and say, we did this at Providence and this really worked or this didn't work. I think that's where my hope lies and motivation.
If one were in need of hospice care for a loved one, what do you do? Do you shop around? Do you interview programs before you decide where your loved one gets placed?
It's hard. Hospices are really good at promoting themselves, and we try to do the same thing. And so it's just like finding a good doctor. It's not easy, quite honestly. The maze of the healthcare system is difficult to navigate. Um, I think you look at start with the nonprofit versus profit status and go from there. And you talk to your primary care doctor, your oncologist, because they have some idea.
Hmm.
And I think too, talking to social workers, case managers at local hospitals, they also have some idea about who are the better hospices.
I think the nonprofits in general are still a reasonable filter to start because they have boards of directors of people in the community they serve owning the program rather than people who may own a program through shares of stock or some holdings in a private equity company. That's not a complete answer. I think I suggest people look at programs that have been in business for 10 or more years. And then I fully agree with what Glenn said. Um, ask if you're in a hospital being referred to a hospice program, ask the social worker who's been seeing you, or the nurses, and kind of call them aside and making direct eye contact, saying, if this was your mom, which hospice program would you call? Again, you know, there are data sets. There's Medicare.gov has a hospice compare website that has some data on various hospice programs. There's something now, a single person, a gentleman named Court Kasner, has created the National Hospice Locator, which has every hospice in your zip code and data about quality and some of their descriptions of the hospice program, including ownership being one category. And yes, if you have a chance, interview more than one program. How many times will my mom be seen per week? Can she see a hospice doctor if we feel it's necessary? What happens after hours?
Yeah.
What happens if the medications she's been given for pain don't work or a new problem arises? Who do we call, and what should we expect happens? So there are other things, but it isn't easy these days, but it's needlessly hard. We've all done more complicated things than this successfully.
Yeah. The other thing that is out there is external certification, which validates our practice, like the Joint Commission. Like our hospice undergoes Joint Commission surveys every 3 years to look at our practice, really examine our records, and see if we meet national standards and guidelines.
Glen, Komatsu, Ira Byock, I'm so grateful not only for your conversation today, but for the work that you've done through the years and the caring that you do still to this day. Thank you for sharing this with us, and thank you for fighting the good fight. Keep on keeping on, as they say.
Yep. Thank you, Seán.
Thanks, Seán. Thanks for having us.
Ira Byock is Emeritus Professor of Medicine and Community and Family Medicine at the Geisel School of Medicine at Dartmouth, and the founder of the Providence Institute for Human Caring. Dr. Byock is the author of Dying Well, The 4 Things That Matter Most, and The Best Care Possible. We reached him in Missoula, Montana. Glen Komatsu is the Chief Medical Officer of the Providence Hospice, Los Angeles County. He spoke with us from Torrance, California. Earlier, I made reference to Eric Cassell's essay, A Simplified Description of the Person, from his book, The Nature of Suffering and the Goals of Medicine. There's a link to the text on our website, but here's an excerpt. Persons have personality and character. Personality traits appear within the first few weeks of life and are remarkably durable over time. Some personalities handle some illnesses better than others. A person has a past. The experiences gathered during one's life are part of a today as well as yesterday. Memory exists in the nostrils and the hands, not only in the mind. A fragrance drifts by and a memory is evoked. A person without a past is incomplete. A person has roles. I am a husband, a father, a physician, a teacher, a brother, an orphan son, and an uncle. People are their roles, and each role has rules. Together, the rules that guide the performance of roles make up a complex set of entitlements and limitations of responsibility and privilege. By middle age, the roles may be so firmly set that disease can lead to the virtual destruction of a person by making the performance of his or her roles impossible. Whether the patient is a doctor who cannot doctor or a mother who cannot mother, he or she is diminished by the loss of function. Every person has a body. The relation with one's body may vary from identification with to admiration, loathing, or constant fear. Disease can so alter the relation that the body is no longer seen as a friend, but rather as an untrustworthy enemy. Everyone has a secret life. Sometimes it takes the form of fantasies and dreams of glory. Sometimes it has a real existence known to only a few. Within this secret life are fears, desires, love affairs of the past and present, hopes and fantasies. Disease may destroy not only the public or the private person, but the secret person as well. A secret beloved friend may be lost to a sick person because he or she has no legitimate place by the sickbed. When that happens, the patient may have lost the part of life that made tolerable an otherwise embittered existence. Such loss can be a source of great distress and intensely private pain. Everyone has a perceived future. Events that one expects to come to pass vary from expectations for one's children to a belief in one's creative ability. Intense unhappiness results from a loss of the future of the individual person, of children, and of other loved ones. Everyone has a transcendent dimension, a life of the spirit. The profession of medicine appears to ignore the human spirit. When I see patients in nursing homes who have become only bodies, I wonder whether it is not the transcendent dimension that they've lost. The Hear Me Now podcast is a production of the Providence Health System and its family of organizations. Find us online at hearmenowpodcast.org. The program is produced by Scott Acord and Melody Fawcett. We have research help from medical library staff Carrie Grinstead, Basha Dolovska-Elliott, Sarah Viscuso, and Heather Martin. Our theme music was written by Roger Neal. The executive producer is Michael Drummond. I'm Seán Collins. Thanks for listening today. Be well.